Thank you all for coming today. I know that this is the last dregs of summer, and for those of you who are still here and attentive, I really appreciate that. It's really easy to be interested in Dr. McDougall, who we sort of take some credit for. We feel like, this is welcome back to Calgary. So, in the early 2000s, Jason showed up and tried to do something almost impossible. So for those of us doing, sort of Black and Decker biology, Jason was a self-acclaimed joint physiologist, and that was staggeringly different. So, and Jason came and did some really excellent work here, and with really that singular focus on joint physiology. And at that time, there were not even a handful of papers. He also was a very integral member of the Canadian Arthritis Network and a very vocal proponent for patient interests as well as scientific interests in pain. And he has subsequently become the chairman of the Scientific Advisory Committee of the Arthritis Society. And we've known each other now for 2 decades. Thank you. And of course, during that work, he's worked not only on cannabinoids and been a vocal and visionary person for that. I was telling him last night at dinner that, when I first heard that medical marijuana might become a priority for funding priority, research priority for the Arthritis Society, I quivered for both the society and for us, actually. But I think that Jason really saw to the quick, and here we are, just literally a month away from a social change, perhaps, in the cannabinoids. And he's going to tell you about that today. He's a national and international presence at the pain societies and an advocate for arthritis in particular at those societies. His resume or his CV is long and glorious, so I won't go over that. How do you introduce someone who needs no introduction scientifically? But I do have 2 things I want to say about him. And one is, when you look at his list of publications, it's really remarkable, and I really admire it because literally it's high quality control. He has an average of about 3.5 authors per publication. So, and I have the glorious honor of being on 2 of those publications, thank you, Jason, both of which have more than 3 authors. So, you can see where I fit into this cog, into this wheel. So thank you for coming. You'll find that Jason is thoughtful, provocative, and equally entertaining. Thanks very much for coming.
Great. Thank you. Thank you very much, John, for those surprisingly complimentary words. I really appreciate it. Lovely to be back in Calgary. Great to see some old friends and meet some new friends as well. So delighted to be here, and thanks, Roman, for the invitation to come and speak. So it is, as John says, it's quite timely that we're talking about cannabis. October 18th we'll have this recreational cannabis will be freely available. Everybody's all worried about how it's all going to pan out, but I think we'll just have a little spike of people taking it up, and then it'll all just settle back down again. But we've had medical cannabis in Canada since 2001. 2001 it was mandated that people should have free access to cannabis to help with a whole myriad of medical conditions, including the different types of arthritis. So I'm going to talk a bit about cannabis and joints, and I'm not actually going to be talking about these specific types of joints, but talking more about the arthritic type and how people seem to be, at least anecdotally, gaining a lot of benefit from using cannabis to help treat and manage their disease. So the whole history and sociological past of cannabis is really a fascinating read, and I just want to delve into just a little bit of the history. So around about 8000 BC, the hemp plant was used in the manufacture of textiles and ropes, etc., and various different types of clothing. The first written use of cannabis medicinally was about 2700 BC. This is Shennong. Shennong took it upon himself to pick 365 different chemicals that he found in his environment and tried them on himself to see what sort of effects they had. As you can imagine, some were pretty radical, and maybe he missed a few days before. But he did use cannabis. He found cannabis helped with his gout, and it's also been found to it helped with malaria as well. So it's been around for a long time as a medical entity. When we come to North America, it was 1611 that the colonial settlers brought hemp over with them. Some of that hemp had more THC in it than not, but that was the real introduction of cannabis into North America was through the original settlers. In the 1800s, there was a huge amount of cannabis research going on, particularly in France and the UK. It was a really hotbed of activity into trying to understand what was about this plant and why it was seemed to be so beneficial for so many different conditions. And in 1850, cannabis was actually part of the US pharmacopoeia. It was prescribable, freely available within the US. And in 1935, there were actually 28 different compounds available to be prescribed that contained various different tinctures and parts of cannabis. There were lots of research and development was going on at this time, so it's really not that far in the past that cannabis was being used and for these medical purposes in particular. And then this all came to a shuddering halt in 1937 by this guy, Harry J. Anslinger. He was a politician, American U.S. politician. He was a bit of a racist. And he wanted to put this Marijuana Act in place. So anybody who was either working with it or trying to use it, he wanted to really heavily tax it. And he went pretty underhand sort of ways about how he was trying to get his point across. He self-appointed himself as the first Bureau of Narcotics, chief of the Bureau of Narcotics. He created this Bureau of Narcotics and then appointed himself to be head of it. And he used to write things in newspapers like Reefer Madness and really trying to say that people who were taking cannabis were really off the head, and it was just a gateway to much worse drugs. And he used this for his own political gain. Maybe sounds a little bit like something that's going on down south at the moment, I don't know. But with this Marijuana Act, that really just shut down the use of medicinal cannabis in North America and any research into it. And it wasn't until 1970 that Raphael Mechoulam in Jerusalem discovered the active constituents of cannabis, and delta-9 tetrahydrocannabinol, or THC, was discovered by Mechoulam and his group. He then went on to discover many of the other different chemical entities that are found in cannabis. So it's got an interesting history. It's got an interesting social history associated with it. And what I try to do is try to shun that Cheech and Chong kind of approach to, when I say that I work on cannabis, everybody gives a little snigger and, oh yeah, can I get some of your stuff that's in your freezer, please? And I want to get away from that. There is a real science behind this, and it's a fascinating science, and it's a really interesting set of and difficult compounds to work with. So what actually is cannabis? There are three main strains of cannabis: Cannabis sativa, Cannabis indica, Cannabis ruderalis. And they produce these beautiful flowers, and there are over 500 different chemicals found within cannabis. So it's a very complex plant, lots of different constituents. There are the cannabinoids. There are various terpenoids which give particular smells and flavors to the cannabis. And anecdotally, certain people are drawn to certain strains of cannabis that have a certain smell. And what we're finding is that some of these terpenes are actually bioactive and can have analgesic and anti-inflammatory effects in themselves. If we focus in on the cannabinoids, there are actually over 100 different cannabinoids. They tend to be lipophilic, so they're really quite difficult to work with in the lab. And as I said, there's delta-9 THC, and also you probably hear about cannabidiol or CBD when people talk about the different chemovars of cannabis. Now, these cannabinoids are found in the oils secreted by the trichomes of the flowering plant, and they're only found in the female plants. So that's just a little bit about the plant itself, the botany. It's frozen. There we go. So the cannabinoids. So what I've just described are the phytocannabinoids, the cannabinoids derived from the plant itself. They can also be manufactured in the lab, and these are the syntheto-cannabinoids. But our bodies also produce their own type of cannabis, which are the endocannabinoids. And the most well-known endocannabinoid produced in our body is anandamide. Anandamide takes its name from an ancient Sanskrit word, ananda, which means pure bliss. And from the pharmacology, there are two receptors, CB1 and CB2. CB1 receptors are located on nerves. CB1 receptors are the most predominant G-protein coupled receptor found in the brain. So beyond any other G-protein coupled receptor in the brain, CB1 is number one. CB2 is more associated with the immune system, although they have been localized on nerves as well. But generally that division is that CB1 typically part of the neuronal system, CB2 more part of the immune system. So within Canada there are a number of different compounds that can be prescribed, cannabinoid containing compounds which can be prescribed. The first one I'm going to talk about is dronabinol. This is just a synthetic form of THC. It's an oral capsule, so it's very easy to administer, and it's been approved for chemotherapy therapeutic patients because of its ability to suppress nausea and vomiting. And it's also been approved for AIDS patients to help stimulate the appetite because of the known effects of cannabis and giving people the munchies. You can tap into this for people who are having difficulty feeding themselves because of AIDS or undergoing chemotherapy. The other one is nabilone. That's also a synthetic THC of a lower dose. Again, it's oral capsule and for the same indications as dronabinol. Then there are various nabiximols. This is a mix of THC to CBD in a pretty much a 1-to-1 ratio. This is a sublingual spray, and it's approved in Canada for multiple sclerosis patients and people with neuropathic pain associated with their multiple sclerosis. And then, of course, we come to the herbal cannabis, and the problem with when you start playing around with the plant or using the plant medicinally is it becomes difficult to narrow down the various different components, all the different cannabinoids, the terpenes, the flavonoids that are found within that. Although people who grow cannabis are extremely proficient botanists and can really try to narrow down the levels and be consistent with the levels of cannabinoids and terpenes found in their particular chemovars. Herbal cannabis is, of course, typically smoked. It's not the best way to administer any drug. The beauty of smoking or vaporizing, which is a bit more safe, is that it gets into the system very quickly. People get relief very quickly when they ingest it in that way. Of course, there are various different oils which can be made into butters, made into cookies, and ingested, so that gets away from people having to smoke the cannabis. But it's a much longer release profile, and people can sometimes think, right, well, this isn't doing much for me. I'll just take a little bit more and take a little bit more, and then maybe find that they've had a little too much. But patients learn this, and they learn over time with using herbal cannabis how to be able to titre the amount of cannabis and the type of cannabis that they require for their particular condition. Whether it's a little bit of something that's CBD heavy to help them get to sleep at night, or something that's got a little bit more THC in the morning to help get them going through the day and managing their pain. The problem with the whole cannabis and cannabinoid field is, I mean, there's growing and great preclinical data supporting the use of cannabis and our understanding of the cannabinoids. What we're really lacking are really good clinical trials. There are very few published RCTs looking into the medicinal effects of cannabis, and some of them are just listed here, you know, for different pain conditions, as well as various types of neuropathy as well. So it really is a call to arms that we need more, especially when with the legalization of the recreational cannabis comes on board. You know, we're going to need a lot more clinical type of trials to delve into the effects of things like safety issues, drug-to-drug interactions, etc. So, as I said about smoked cannabis, it's great. It's absorbed very readily by the lungs, gets into the system very quickly. It's easy to titer. Maybe patient just needs 1 or 2 puffs, like I say, before they go to sleep, and that's all they require. It can improve their sleep. I remember giving a similar lecture once, and the arthritis patient, this lady, elderly lady, came up to me and said, you know, I've been trying all these different drugs to try and manage my arthritis, you know, the NSAIDs, the opioids, the gabapentinoids and everything, and nothing seemed to work. And she always shunned cannabis because of the negative connotations associated with taking cannabis. And she finally broke down, and somebody had brought her some cookies one day, and she tried it, and she says that was the first good night's sleep she'd had in 30 years. So she was a convert to the use of cannabis for her particular condition. One of the other things is it's a great anxiolytic, taking cannabis, and people who are in chronic pain obviously feel a lot of anxiety because of their pain condition, having to live and manage their pain, and cannabis has been found to be very useful in those patients to help them cope with their disease. Of course, we can all recognize the disadvantages of smoking cannabis. It's not the safest way, it's not the best way of administering the drug. It's not appropriate for all patients. So young children, maybe with Dravet's syndrome, you wouldn't give them a joint to smoke. That's why they have various different oils. That seems to be very effective for the pediatric population. Of course, there are known psychotropic side effects with smoking cannabis. And again, the consistency and the levels of the cannabinoids and the non-cannabinoids within each particular strain is sometimes quite difficult to monitor and maintain. And this is just a slide I stole from John Page, looking at, these are 210 different strains of cannabis from 15 different licensed producers across Canada. And we're just on the x-axis here, the amount of THC, so the psychoactive component of cannabis, versus CBD, which does not have any psychoactive effects. And you find that the majority of the strains really have very little CBD or no CBD, but quite varying amounts of THC. And there's really only one instance here where there's a strain with CBD but no THC in it. And so the average amount is around about 18% THC versus only about 0.3% CBD currently. So you can imagine, you know, these strains are going to have different effects in different patients, and that's one of the other things that we're going to have to research in the future is which one is going to be effective for which type of patient and at which stage of their disease. One of the interesting things when they legalized cannabis in different states in the US, what they found is that there was a rapid reduction in the amount of other pain-killing drugs that people were suddenly taking, and in particular the opioids. So before using cannabis, you know, there was about 65% of the patients were using opioids, but after the legalization of cannabis, only about 18% of these patients were now taking their opioids, sorry. So there seems to be this opioid sparing effect of people who use cannabis. They seem to be able to give up their use of opioids and NSAIDs, and we know that the negative side effects from chronic NSAID use, that was also dramatically reduced from 62% down to only 21% of patients continuing with their NSAIDs because they were taking medical cannabis. So who's taking this cannabis? So this is data taken from the Canadian Consortium for the Investigation of Cannabinoids, as well as from Health Canada. It's a little out of date. I keep pushing Health Canada to give me more updated numbers. But this is just a breakdown of the different disorders that people would be potentially taking their medical cannabis to help manage their condition. And you can see that the vast majority of people who are prescribed and taking medical cannabis are doing so for the management of the arthritis. And the latest estimate is that, in fact, 65% of medical cannabis users are arthritis patients. So at least anecdotally, there seems to be some good evidence that arthritis patients are gaining some benefit from taking medicinal cannabis. And there's really only been one clinical trial looking into the effects of cannabinoids in arthritis. This is from David Blake's group in the UK. This was published as an abstract at a conference. It's a relatively small number of patients, only 58 rheumatoid arthritis patients. It was a double-blind placebo-controlled RCT. And they were given Sativex, which is a nabiximols, which is that half THC, half CBD. And the patients reported great pain relief, really improved their ability to fall asleep at night and get a good night's sleep with their chronic pain condition. The side effects that were reported tend to be relatively mild to moderate, so dry mouth was one thing, and of course some feelings of highness as well by taking because of the THC. But it really just points to and pushes that we need a lot more clinical trials in the world of cannabinoids before we can have a greater confidence in their medical use. Okay, so that's kind of a bit of a background. I became interested in the cannabinoids when I was here in Calgary, and I was talking to Keith Sharkey, who most of you know, I'm sure, who works on cannabinoids in the GI system. And I said, just asked the simple question, I wonder whether there are cannabinoid receptors in joints. And so we went away and did some immunohistochemistry, and right enough, we found CB1 receptors present in the joint. And that really then allowed me to go on and ask some pretty fundamental questions about why are they there, and can we tap into them to be able to regulate and modulate disease in various different arthritic conditions. And the idea about giving these things locally is that we can treat the disease at the source where the pain is occurring and the inflammation is occurring. And the idea is for those cannabinoids not to be able to get into the central nervous system, and so we can avoid a lot of the highs and the psychoactive effects of using the cannabis. So just want to share a story that we did with, that we just published last year, looking at cannabidiol, or CBD. So CBD, as I've said, is a major chemical component of cannabis. As with all the other cannabinoids, its amount varies by strain. The thing about CBD is it has no psychoactive effects whatsoever, apart from making you feel maybe a little sleepy. It doesn't get you high. It's a very safe drug. You can eat grams of this stuff, and it won't have any detrimental effect on your. So the toxicity level is extremely high for CBD. Even so, trying to work with CBD and getting a hold of it from Health Canada, you still had to go through all of the rigmarole and filling out all the paperwork, and just because it had that cannab bit in front, that Health Canada just got all twitchy, but even though it has no psychoactive effects whatsoever. So we wondered what would happen if we were to administer this in our models of arthritis. So this is the pain pathway, simplified. So our joints and other tissues, of course, are richly innervated with sensory nerves. And some of these sensory nerves are very exquisitely sensitive to noxious or painful stimuli. These are the nociceptors. And they send their information up to the dorsal horn of the spinal cord, and then via ascending processes to various regions of the brain, and the brain interprets all this electrical activity as pain, as where most of us are, or just about all of us are aware of, and as well as activating deeper structures within the brain that gives it that emotional component to pain as well. So it's not just the ouch, move away, but there is a very strong emotional component to pain sensation. So what we do in the lab, in my lab, is we can record from these mechanosensory nerves within the joint, and we record electrophysiologically single unit events in response to mechanical rotation of the joint. So we can rotate the joint within the normal working range and measure the firing frequency of those sensory nerves, and then we can crank on that joint and give it a noxious hyperrotation that would be considered painful in a normal in an alert animal, and just basically count the number of action potentials in response to these two different types of movement. And then we can locally administer various drugs, and in this case CBD, we administered it locally into the joint and measured before and after administration. So single unit recordings, the two different types of, in this instance we just wanted to look at noxious hyperrotation of the joint, so a painful stimulus. And as I said, cannabidiol administered locally to the joint, and we did these recordings in a chemical model of osteoarthritis. This is the monoiodoacetate model of osteoarthritis that we used in these particular experiments. So here are single unit recordings. So pre-CBD and post-CBD. So what I'm showing here is torque, increasing torque and rotation of the joint, and hold it for about 10 seconds. And this is the electrical activity in response to that hyperrotation of the joint. And you can see that the nerve fires at a pretty high level, pretty high frequency. That high frequency of firing would be transmitted to the central nervous system, and the brain would interpret that as pain. And you can see that when we give a single local injection of CBD to these osteoarthritic joints and do exactly the same type of movement, the number of action potentials is significantly reduced compared to pre-CBD administration. So we were able to show quite clearly that local injection of cannabidiol into the joint has this anti-nociceptive effect. So that's fine, that's anti-nociception. It's a very powerful tool of objectively assessing pain or nociception in our model. But we do behavioral studies as well, where we assess various different pain behaviors in our arthritic model. So we use von Freiherr algesiometry. So this is where the animal's in a little plastic box like this, and the floor of the box is a grid which gives us access to the hind paw, and we can apply various filaments of various different forces to that hind paw of increasing force, and as soon as the animal feels it, it will withdraw its paw away from that physical stimulus. And of course, you can imagine if the animal's got a painful joint or a painful paw, that it would take less of a bending force for the withdrawal to occur. And that's what's shown here. So this is the withdrawal threshold. Anything that's going down the way is indicative of more pain. This is before injection of the chemical that produces osteoarthritis. So it takes around about 15 grams before the animal will withdraw its paw. And you can see vehicle in purple here compared to CBD in green, that the withdrawal threshold up to around about 3 hours after injection is dramatically improved. So that pain behavior is being reduced by this single injection of cannabidiol. The other technique that we use is weight bearing. So we modified this static weight bearing system to include this tube. And just inside this tube, you can put a little bit of peanut butter or something tasty for the rat, and you train him to stand on his hind legs for about 5 to 10 seconds. And underneath the hind paws are a couple of force plates, and it's basically just measuring how much weight it's putting on one leg versus the other. And of course, if it's arthritic, it's going to be shifting its weight onto the other leg. And what we find here, so at pre-MIA, that it's around about 50-50. The animal's pretty well balanced on its hind limbs. You give the osteoarthritis and it shifts its weight onto the other leg, and we were able to reverse that with, again, this local injection of cannabidiol into the joint. So it's having an anti-nociceptive effect because of the reduced firing of those pain-sensing nerves, and behaviorally, it also seems to be reducing the pain in this model of osteoarthritis. So that was a cannabinoid, a phytocannabinoid, so from the plant. As I mentioned before, our body also produces their own type of cannabinoids, the endocannabinoids, and we did some studies to see if we could tap into that endogenous system to try and reduce joint pain. So endocannabinoids are produced in cell membranes from arachidonic acid, and the thing about the endocannabinoid system is that it's only switched on when there's injury or there's some sort of inflammation or some sort of disease. So if everybody's normal and everything's hunky-dory, you're not releasing endocannabinoids. It's only switched on when there's a problem. So following an injury, anandamide is produced, it's released in the extracellular space, it can bind to its cannabinoid receptors, but then it's rapidly taken into the cell via this anandamide membrane transporter. So it's rapidly brought back into the cell and broken down by an enzyme called fatty acid amide hydrolase, or FAR, into its constituent parts, ethanolamine and arachidonic acid. So one of the techniques and approaches that people have been using is to try and maybe block the enzyme that is causing hydrolysis of the endocannabinoids. And this drug here, URB597, is able to do that. And so if we block that enzyme, the idea is that we'll hopefully bolster the amount of endocannabinoids within the joint. So we'd identified CB1 and CB2 receptors in the joints of rodents, so that would be guinea pigs and in rats. Group in the UK had been able to identify CB1 and CB2 receptors in the synovium of rheumatoid and osteoarthritis patients, as shown here. And they were also able to identify and isolate endocannabinoids, various different endocannabinoids within the synovial fluid of these OA and RA patients, so things like anandamide and palmitoyl, ethanolamide, etc. So they're certainly present in the human population. So we did some experiments. Again, we did some electrophysiological recordings. We looked at noxious rotation of the joint. We locally administered this FAR inhibitor, URB597, to see if it would have any effect on joint afferent firing. And we did recordings in normal joints, as well as this would be in the guinea pig model of osteoarthritis this time. This was the Duncan Hartley guinea pigs which spontaneously develop osteoarthritis. So first of all, a control normal joint. These are just the receptor fields from which we did our recordings. Here's our noxious movement and the electrical activity from the mechanosensory nerves in response to that. And you can see that URB597 doesn't do anything. And that's what we'd expect. These are control joints. There's probably no endocannabinoids being released. However, when we repeated the experiments in our model of osteoarthritis, again, you can see that URB597 dramatically reduced the afferent firing rate within these osteoarthritic joints. There's a question at the back. Guinea pig. That's guinea pig. Guinea pig, yeah, of natural osteoarthritis. So yes, it dramatically reduced the afferent firing of those mechano-nociceptive nerves. We did some further pharmacology to try and identify which receptors are being involved in this endocannabinoids system. So we treated them with a CB1 antagonist called AM251, as well as a CB2 antagonist, AM630. And AM251 was able to reverse this fairly mild change in hind paw weight-bearing deficit. The improvement of that by URB597. So it seems to be predominantly working through the CB1 receptor, which anandamide is known to work through anyway. So just to summarize that, if we give a local administration of cannabidiol into an osteoarthritic joint, we're able to reduce the primary afferent nerve firing as well as pain. If we locally block the breakdown of endocannabinoids within the joint, we can also inhibit nociception and pain. And so it looks like, these cannabinoids are a very good target for locally reducing pain within the periphery in osteoarthritis. But there are many different types of osteoarthritis, and there are many different types of pain. So pain is really a heterogeneous experience. There's really nociceptive type of pain, so that because of the tissue breakdown in arthritic joints, there's an alteration in the biomechanics, of course, of those joints, and you have bone on bone quite often. And that nociceptive pain is really the grinding that's occurring within those joints. That would be nociceptive pain. There are other patients osteoarthritis patients who have an inflammatory component to their osteoarthritis. And that's, of course, due to accumulation of various different inflammatory mediators within the joint. And so they have this throbbing, sort of burning type of pain. But more recently, we're finding that there's a subpopulation of patients, of osteoarthritis patients. We reckon maybe about 30% of osteoarthritis patients have actual damage to their peripheral nerves. And so there's a neuropathic type of pain that's occurring within those patients, which would be responsible for giving a feeling of like a stabbing electric shock type of pain. And this kind of makes sense that there's going to be different phenotypes in different patients, because typically we've been treating osteoarthritis patients with analgesics that are anti-inflammatory. So NSAIDs is the number one go-to for an osteoarthritis patient. But if they've got a neuropathic component to their disease, these compounds aren't going to work at all, or they're not going to work very well. So what is the evidence that there is a neuropathic component? And this again is work I did here during my postdoc with Keith and Bob Bray. And in this study, we looked at the morphology of the nerves within, this is going back quite a few years ago, in these injured joints. So you can see in a normal joint, the nerves are nice and regular, they're nice and fine, they're very easy to identify. However, when there was an injury to that joint, as you can shown in the bottom panel here, those nerves clearly don't look normal anymore. They're all tangled, they're truncated, they're varicose, they've got swellings to them. And this is really, although we didn't mention it at the time, but looking back on these things, this is consistent with a peripheral neuropathy. These nerves are not normal, they've undergone some sort of structural change. Other groups, people at Pfizer actually, looked in that monoiodoacetate model of osteoarthritis, looked in the dorsal root ganglia, and they looked at a biomarker of nerve damage called activating transcription factor number 3, or ATF3. And on the bottom here, you can see a control versus a DRG from an osteoarthritic animal. And the expression of this ATF3 is dramatically increased, indicating that there is nerve damage occurring in the peripheral nervous system of these animals. So there is this peripheral neuropathy. So,
are you talking about motor and sensory nerves, or both?
predominantly sensory nerves. So in the joint, about 80% of the nerves are sensory.
So motor nerves are affected?
Well, we haven't looked at motor nerves. That's not strictly true. We started to look at different diameter neurons, and the larger motor neurons are affected. They undergo demyelination as well. But these were stains for sensory nerves. They were peptidergic nerves that were in the joint. That's what I was showing there. Okay, so how could the endocannabinoid system, could the endocannabinoid system be beneficial for helping maybe repair these nerves? And there's some really good evidence that cannabinoids are good at repairing damaged nerves. So multiple sclerosis patients, for example, which is a centrally mediated demyelinating disease, they take cannabis for the management of their pain, but it's been found that it can actually have these cannabinoids can have a neuroprotective effect and actually reverse the damage that's occurring in their neuropathy. So there's pretty good evidence linking cannabinoids for neuroprotection. So we wanted to ask that very question: could the endocannabinoid system be tapped into and help protect the arthritic joints from this demyelination? So we did a prophylactic a series of experiments. So in the early phase of the osteoarthritis, we gave on 3 consecutive days just a local injection of our URB597, so the fatty acid amide hydrolase inhibitor. And then we left the animals all the way out to 14 days. We looked at pain, and we also looked at their what's called a G ratio, which gives you a measure of myelination of those sensory nerves. And we'll start with the myelination. So under electron microscopy, so we take the saphenous nerve and we section it and look at the thickness of the myelin sheath of the individual nerve fibers. And you can see in our model of osteoarthritis, or maybe you can't quite see, but in the model of osteoarthritis, there's a demyelination occurring. The myelin sheath is thinning, and in quite a lot of instances, there's actual loss of myelin around those nerve fibers. With the prophylactic treatment of the endocannabinoid hydrolysis inhibitor, URB597, we were able to rescue or prevent, I should say, the development of this demyelination within this particular model. And that's just shown graphically at the bottom here with our G ratio. So G ratio is just a ratio of the internal area versus the total area of the nerve fiber. And anything that's larger indicates demyelination. So osteoarthritis, demyelination, and able to at least prevent that to an extent with the URB597 prophylactic treatment. So also we did pain experiments in those, as I said. When you treat the animals with vehicle, there's a reduction in their withdrawal threshold, so indicative of pain in these animals. And again, reversal of that by prophylactic treatment with URB597. So it's having an analgesic effect. So what else can these wonderful drugs do? So we've seen that they can be neuroprotective. We can see that they can be analgesic. What about inflammation? What about joint inflammation? So, of course, just quickly, in a controlled situation, leukocytes flow rapidly through the vasculature. However, during an inflammation, there's a signal from one of the endothelial cells. You'll have this rolling phenomenon of the leukocyte, adherence of the leukocyte to the internal part of the vessel, and then gradual extravasation out of the vessel into the tissue, where it then releases all its active goodies to cause inflammatory response. And those active goodies found within the leukocytes can also sensitize the nerves, leading to pain. And so we use intravital microscopy, where we can label the leukocytes with rhodamine 6G. We can then, an anesthetized animal, expose the knee joint, and then under fluorescent microscope try and quantify the trafficking of these leukocytes, so the amount of rolling, the amount of adherence that's occurring in our models of arthritis. So these experiments were done on C57 black mice. It was a model of acute inflammation this time. We did the intravital microscopy, and we used our URB597 at this dose to inhibit endocannabinoid breakdown. So hopefully I've got a video that will work here of one of our intravital microscopy experiments. Yes. So this is an inflamed joint, just at control. Here's a blood vessel in the synovium of the mouse knee, and you can see there's lots of leukocytes that are either rolling or they're adherent to the internal surface of the blood vessel. So clearly an inflammatory response here. This has now taken 20 minutes after local administration of URB597, and you can't even quite see it probably with these lights, but there's a blood vessel here, and yeah, I don't know if you saw that quickly there, but there was a leukocyte that flew past and everything. Oh, here's one. Don't know if you can quite see that guy. Yeah, so there is something there, honestly, but you just can't quite see it under here. So it seems to be having this anti-inflammatory effect or an inhibitory effect on leukocyte trafficking, which was quite nice. So just to summarize, local inhibition of endocannabinoid breakdown reduces leukocyte trafficking in this model of acute inflammation. By promoting the endocannabinoid system, we think that this could be a very effective way of treating osteoarthritis and of various different arthritic conditions from an inflammatory standpoint as well as a pain standpoint. So we were feeling pretty good about ourselves, patting ourselves on the back. This is my football team, Wally. This is Sunderland. It is a very old picture. This is the last time they actually won anything. So this is 1973. Wally and I have a little bit of banter about the football. So yeah, we were feeling pretty good about ourselves, about that we managed to identify this target. And then it goes just like all good things, that they stupidly try to do it in the clinic. And I don't know if you recall this tragic story about what happened. This was a clinical study in France. It was a Portuguese company had produced a FAR inhibitor, this compound here. And it was a phase 1 clinical trial, so healthy subjects had to be stopped because one of the patients died and there were 2 other patients in a coma. And in Science just last year, it was discovered that that this particular FAR inhibitor was having multiple off-target effects, particularly in the brain, where it was actually inhibiting enzymes that are involved in neurodevelopment and neurosprouting and things like that. So that was a bit of bad news for us working on FAR inhibitors. Prior to that, there was a study done in osteoarthritis patients by Pfizer using their particular FAR inhibitor, and they found that it was ineffective at reducing osteoarthritis pain in this particular study. It was no better than using an NSAID, but you could still argue using a FAR inhibitor might be safer than using long-term NSAIDs. I would say there are a number of different problems with this study. I mean, first of all, the drugs are given systemically, and as I've been showing you today, maybe if we target it locally within the joint, that might be more beneficial and have less side effects associated with these FAR inhibitors. These FAR inhibitors are also known to promote various different alternative pathways, particularly through the TRPV1 ion channels. So they're known to sensitize TRPV1. This was known to sensitize TRPV1 ion channels, also causing the release of various eicosanoids like prostaglandin. And as I've said, osteoarthritis is not osteoarthritis is not osteoarthritis. There are many different types of osteoarthritis that we're just currently trying to subtype. Equally, there's many different types of pain that we're also trying to subtype. And within this study, they just put everybody as an osteoarthritis patient together. And I think maybe what we need to do is subdivide, and this is how clinical trials in the field are going forward, that they're trying to subgroup osteoarthritis patients based on their particular disease phenotype, and maybe treating them separately as opposed to just a homogeneous population. So what I've hopefully shown you today is that there's pretty good anecdotal evidence that cannabis and the cannabinoids and the endocannabinoid system could be very beneficial for people living with chronic arthritis. The scientific evidence is gradually building. We've got a pretty good preclinical evidence, and some of which I've shown you today. Of course, it's not suitable for all patients. Not everybody is going to get benefits from the cannabinoids. Not everybody should be taking cannabinoids necessarily, and we still need to work out some of those drug-to-drug interactions. So if an elderly patient could be taking multiple different drugs for different conditions like hypertension, or maybe they have a late onset diabetes, how does cannabis and the cannabinoids interact with the drugs they may be taking for those conditions as well? We need to answer those questions quickly. And we really need better ways of administering cannabis. I mean, we can't give people joints and expect them to smoke their joints. Vaporizing, as I said, you can use vaporizers, which is safer, but still there's, so you have these e-joints instead of e-cigarettes. There are e-joints, and so they seem to be a bit better, but there's still some noxious mediators, chemicals found within those e-joints. And ultimately, as we always keep harping on, we need to do more research, particularly in I would say in the clinical world. So we'll just keep searching for the answer. But what I'm hoping to do as well is just to get us thinking about cannabis and taking cannabis as this, the reefer madness, etc. And then hopefully I've maybe started to convince you that there is a serious science behind this, and they are viable mediators to look at. And that maybe in the future we'll be talking about cannabinoids more like this, like an intra-articular injection or a patch, and people are developing various different types of creams that can be just applied to the joint to try and alleviate the symptoms as well as the disease process. And I didn't show you some data today, but it's been shown that cannabidiol can actually reverse some of the destruction that occurs within arthritic joints. So it seems to be the wonder drug. Okay, just remains for me to thank people in my lab who worked on this project. I collaborated with Eli Lilly on the endocannabinoid studies. I'd like to thank all these people who contributed and helped pay the bills for this. And this is just a picture of the lab at the moment. And I always finish off with my wee poem. I always try and put this into a little perspective with my wee poem. So this is my cannabinoid wee poem. So when people ask me what's the point of putting cannabis in my joint, I tell them they should never hide from the absolute bliss of anandamide. Its use in vivo is somewhat fraught because its half-life is rather short, but block the enzymes that break it down and anandamide regains its crown. To alleviate arthritis pain and avoid the highs inside the brain, inhibit far and knees until it's CB1, joint pain nil. Yes. There we go, thank you.
A very hard act to follow. I know Jason would be very willing to take some questions from the audience, so I'm going to, since this is being podcasted, I will walk around to keep her live, Jason.
Okay.
That was fascinating, Jason. Thank you so much. So regarding the expression of the CB1 receptor in the joints, did you compare the expression of CB1 and CB2 in baseline normal joints versus inflamed joints? And would you, for example, during the arthritic pathway have an overexpression of CB1 and now an induction of CB2 expression along that same line? Mm-hmm. Could there be a way for cannabinoids to act through the inflammatory pathway via CB2 in that context? So a complex question.
Yeah, no, it's a good one. We have done it for CB2. We haven't done it for CB1. So we've only done CB1 expression in normal joints at the moment. It's quite difficult to get these things to work. But with CB2, certainly there was an upregulation of CB2 expression both within the joint as well as in the dorsal root ganglia of arthritic animals compared to normal animals. Whether there's more of a shift then, so you're thinking a shift from in a normal situation of being a CB1 driven thing to and in a CB2 being more in inflamed. A multifactorial, yeah. Pharmacologically, both pathways seem to, actually that's not quite true. Pharmacologically, CB1 is very effective at, as I've shown today, at reducing pain and inflammation. CB2, I don't know whether it's some of the compounds that are available that aren't very selective, but in our hands, we have difficulty finding CB2 having any beneficial effect, even though the receptors are expressed there. So we don't quite know why. Maybe it's just the tools we have available.
So in the one RCT that you mentioned with 58 patients, were there responders and non-responders?
Good question. Whether responders or non-responders, I can't remember because it was just it was a very short abstract and they didn't talk about whether everybody responded or not. So I don't know the answer to that. Sorry.
That might be something to consider mechanistically.
Yes, I mean, yeah. I would have thought there would have been responders and non-responders. You know, just like
my second quick question: are all of your studies done with male mice or mice and rats?
They were, but not anymore. So yeah, they were all done with male animals. We started looking at female animals. The thing about the females is that they don't actually develop as much pain. So that's counterintuitive, because you ask, humans and female humans. Sorry? That's in mice, yeah. So human females will report more arthritic pain, and there's higher incidence of arthritis, as you know, in females compared to males. But when we come to do our rats, they don't seem to show as much pain as the males, even electrophysiologically. So even when we do the recordings from the sensory nerves, the females aren't as sensitized as the males. So it's something we're starting to investigate now. Yeah.
Yeah, Jason, I can't overemphasize how important this direction is in terms of understanding the many compounds. As you know, Roger Pertwee wrote that review, and there are 101, and there are going to be more with people cultivating different plants. My question has to do with where you found the receptor with Keith, and specifically the impact on macrophage function, because what we're finding, and we have lots to talk about, is that you find CB1, CB2 receptors in places you never expected, and we find them in macrophages, we find them in HEK cells, we find them in lung cells. So my question about the joint is there an impact on the macrophage in the joint?
Well, as an effect on the trafficking, which I showed. But
yes, that's trafficking of inflammatory cells in.
Yes.
What we're finding is an impact on M0 to M whatever differentiation.
So specifically to the joint, I don't know.
Okay. Then the second question is, I really like the cannabidiol work, because I think you can go a lot farther with that than the enzyme inhibitor.
Right.
And my question is it understood what the target is?
So yeah, that's a big debate in the cannabinoid field, what the target for cannabidiol is. I mean, some people have shown it to be acting through classic cannabinoid receptors, but that's quite rare. There's an orphan receptor, GPR55, is alleged to, cannabidiol is alleged to act through. So at the end of the day, we're still not 100% sure which receptor cannabidiol is working through. Okay, sure.
Jason, one of the visions of the McCaig Institute is a pain-free society. But I think we need to remind ourselves that pain is a useful response that protects from damage. So the administration of cannabinoids in a preclinical person, an athlete who's participating while taking cannabinoids, you could argue is setting themselves up for more severe joint injury and damage just because of the lack of that kind of sensation. We've known that certain sensory inhibition and loss of sensory feedback in the joint leads to Charcot joints. So it's going to be a difficult task to get that balance between, the inflammatory side and the protective side. And in John's sheep, that have transected joint structures, you could predict that cannabinoids is actually going to make them worse if you keep them on the treadmill, if you get rid of the pain, because they're going to start pretending that joint is okay.
So I think that's maybe, you're not trying to get rid of the pain completely. You're just trying to normalize pain. And this came up with the whole NGF story, recently in osteoarthritis patients that were given NGF, and it was the monoclonal tanezumab was taken out of the trials because people were rapidly developing really quite severe osteoarthritis lesions. It later turns out that those patients were also taking NSAIDs on top of the NGF inhibitor. So I don't buy that. What we want to get is rid of the pathological type of pain, but maintain some level of normal pain. And I think still the cannabinoids could fit into that window of normalizing pain, because as you saw, even in our electrophysiology, there's still some activity of those sensory nerves. It's not blotting it out completely. And so I don't think we'd end up with Charcot arthropathies either in that respect.
Two quick questions up here, then we'll...
it's a great talk. So I'm wondering whether you said you got CB1 and CB2 in synovial fluid of the joint.
I didn't. A group
yeah,
in Nottingham
sorry.
did. Yep, yep.
Yeah. So I'm wondering, have you checked which type of cells, like cerebral fibroblast or any other cell types which secreted these receptors in the fluid?
Yeah, it's probably from things like synovial fibroblasts that these mediators are being released, but they just looked at. I mean, they're really difficult compounds to work with because of their lipophilic nature, and I think sometimes it's quite heroic that these people are actually able to identify and quantify endocannabinoid levels in different tissues and fluids, but they didn't specify which particular cells were releasing them.
Thank you.
Thank you so much for the amazing talk. I have a quick questions. The first one, when you were trying, or you discussed the identifying of the endocannabinoids, I hope I'm saying it right, in RA and OA joints. Have you tried to see it in normal, healthy joints?
Yeah, we wouldn't expect to see it in normal joints because the endocannabinoid system is only switched on when there's a disease or an inflammatory situation occurring. So we wouldn't expect to see them in control joints.
Okay. The other question is, I might be missed it in the first part of the talk. Have you tried to inhibit the breakdown of the endocannabinoids locally in the joint?
Yeah, that's what we were doing there. That was
Okay.
with that URB 597. That was done locally within the joint. We've also, although we haven't published it yet, we've looked at other endocannabinoids, so 2-arachidinyl glycerol, 2-AG, and that also, if we inhibit the enzyme that breaks down 2-AG, that also has very similar effects to the FAR inhibitor. And what we've also found is if we co-administer a coxib with this MAG lipase, the 2-AG enzyme inhibitor, we get a potentiation of effect. So the beauty of that, we think, is that we can reduce the amount of coxib that somebody needs to take by having a MAG lipase inhibitor on board as well. So the MAG lipase story, the MAG lipase is in rats. Yeah.
I'll defer for honor's sake here, Dr. Hart, for the last moment.
Okay. I guess my question relates to where's the pain coming from? When you crank on the joint to mechanically stimulate it or whatever, you'd think that might involve the capsule, which I think a long time ago you had a workshop that showed that the capsule was really understudied, and we tend to think of the usual suspects, the synovium and such. But so do you think most of the pain is actually centered from the capsule, which is highly innervated?
I think it's the synovium, and probably a combination of the synovium and the capsule, because that's where the majority of the innervation within the joint is. We know it's not going to be cartilage. It could be subchondral bone because of if there's exposure of nerves in the subchondral bone. But in our experiments, maybe a little bit of ligament could be involved, but I would say the predominance is from the synovium.
Okay, thank you very much, Jason. I'd like to everyone give a hand to Jason for coming up. Thanks very much. We really appreciate that.
Just again, like to thank you very much, Jason, for coming and sharing this with us. And then also just wanted to thank the McCaig Distinguished Speaker Seminar Series for supporting Jason's travel to come out. And so here's half of your present, and the other half of your present is upstairs, and we'll get that for you.
Lovely, thank you very much.
Yeah, thank you very much.
Is it a whiskey glass? Thanks. Thank you.